Hi, everyone. Welcome back to the Doc Talk podcast. I'm Dr. Shazma Mithani.
And I'm Dr. Sheila Wijaya-Singha.
A special thank you to today's episode sponsor, Figs. So obviously in our line of work, you kind of live in your scrubs. And if you follow us on Instagram, you probably already know this. We are obsessed with Figs. They're super comfortable, breathable, and durable. And of course, they actually fit, which is a huge upgrade from the horrible, itchy scrubs that were status quo for so long. They're also just super cute and stylish. And so you just feel good wearing them, you know?
Yeah, and like you said, Shaz, we're obsessed. You know what I love most about Figs, though? They just get what it's like to work in this field. It's not just that they know what we need, like 7 pockets to carry all our stuff around on shift. They've also built this incredibly supportive community of people who want to have important discussions and make real connections with other people who work in healthcare. I've been to a couple of the events they've done, and it's so refreshing for a brand to show up in such a real way. And if you're not following them on social media, guys, the memes. If you work in healthcare or know somebody who does, Figs is it. And right now, if you go to wearfigs.com and use code FIGSCA, FIGSCA, you can get 20% off your first order. That's wearfigs.com, code FIGSCA.
In this special episode of the Doc Talk podcast, we're diving deep into a condition that affects 1 in 5 Canadian children, and that is eczema. We're joined by pediatric dermatologists to break down everything parents need to know from itchy beginnings to effective treatments.
So we're going to explore why eczema happens, who it affects the most, and the role of genetics, environment, and even food in how it may or may not trigger flare-ups. Plus, we're going to ask questions that you've been sending us, like can kids outgrow eczema? What can you do before reaching out for a prescription?
So whether your child is struggling with their first flare or whether you're navigating a long-standing diagnosis, this episode is packed with practical, evidence-based advice and a whole lot of compassion.
So I'm really excited to introduce our guest today. I refer to her often in my practice, and she's a wonderful advocate in the dermatology world and is so well esteemed in Toronto and beyond. So Dr. Marissa Joseph is an associate professor at the University of Toronto and medical director of the Ricky Kanee Schachter Dermatology Center at Women's College Hospital. She also practices at the Hospital for Sick Children, or SickKids, caring for children with complex skin diseases in both clinic and inpatient settings, and she leads a pediatric laser program. Her clinical practice spans general adult, pediatric, and surgical dermatology. Dr. Joseph is recognized internationally for her expertise in pediatric dermatology, inflammatory skin disorders, and equity, diversity, and inclusion in dermatologic care. She has authored book chapters and numerous peer-reviewed articles and has been recognized for excellence in teaching at the University of Toronto. Her vision for the field is simple and ambitious: equitable, high-quality dermatologic care for everyone.
Thank you to Dr. Joseph, who is joining us thanks to Aveeno Baby. Welcome to the show.
Gosh, thanks so much for having me. I'm thrilled to be here.
So, I mean, this is a big topic. I as an emergency doctor, I work in pediatrics as well, see a lot of eczema. I know, Sheila, you mentioned, I'm sure you see a lot of eczema. And
all
this
the time.
is just, I mean, these are questions. It's such a common condition. 1 in 5 kids will have it. And it is something that can be quite distressing, not only to the child, but to parents as well. So can we start by just kind of leveling the playing field? Can you tell us what exactly eczema is? Is it the same as atopic dermatitis?
Oh, yeah. So, even the terms can be confusing. So eczema is atopic dermatitis, which really refers to an itchy, chronic, a rash that's associated with dryness that comes and goes in pretty characteristic areas. And about 70% of cases of eczema start in the first 5 years of life. So kids are definitely disproportionately affected.
And why does it happen? What is actually going on in the skin?
There's so many times, I feel like I have this conversation multiple times a day with poor, worn out, tired families who've been up all night with a kid who's scratching. And I always start off with, it's nothing you did. It's nothing you did. I think people come in with a lot of baggage. Everyone has an opinion. Sidebar, when I had my first child, of course, the universe is not going to let me have a child who doesn't have atopic dermatitis. And so, in some ways it changed the way I practice because everybody kind of in my life knows what I do. They know where I work. And everyone had an opinion, from the neighbors to, stop eating this, don't do this. And inherent in that messaging is you're doing something. You're doing something, bringing your child into something in their environment that's causing it. So I always start with, it's nothing you're doing. It's not a food allergy. And we can get into that because that's a common theme. Really what it is it's a condition that has to do with the skin barrier. So I often say that your skin's your most important organ for a lot of reasons, but two main reasons is that, number one, it's a structural physical defense to the outside world. And then it's also the first line of your immune system. And so in people who have eczema, and this can be genetically inherited, the building blocks or the brick wall of your skin has cracks in it. That's the dry skin, because you inherit these proteins that aren't as good as holding on to water as someone who doesn't have eczema. So you have these cracks in the brick wall, which is a loss of barrier function, both physically, but also as it relates to the immune system. And that allows allergens or things in the environment to then get into the skin. So what does that mean? The body reacts. The body does what it's supposed to. The skin defends itself. That's the eczema, that inflammatory reaction to multiple things. So when we translate that for families in terms of what's the root cause, people will come in and ask, well, is it one food? Like, what can I eliminate? Or is it a product I'm using? And the truth is, it's everything. If your skin barrier is compromised, on a Monday, it could be someone's perfume that triggers you. On a Tuesday, it could be a child crawling in the grass. On a Thursday, it could be a popsicle dripping on their hand. All of these things normally wouldn't have an audience inside the skin if the skin barrier were intact. So eczema, at its core, is a skin barrier function issue.
I love that so that is the
helpful.
most simple way eczema.
Yeah.
And so we have gone through so much training. That is the most simple way eczema has ever been explained to me. And it really just makes so much sense. I do like how you also pointed out, we often forget that the skin is an organ. It's actually our largest organ. And thinking about it in that way, I think is really important when thinking about diseases and conditions of the skin. You mentioned that there is certainly this tendency, not only in medicine, but outside of medicine, when we're talking to people that we know, where we jump to like what is being done that could be triggering this. And you mentioned that there's genetics that are a part of this, probably, I assume, a big part of this. So what role do genetics and family history play in the development of eczema?
So there's a subset of people that don't have a strong family history, and sometimes family history gets lost because if you happen to have very mild eczema early in your life, a few decades ago, we didn't have social media, and so people don't necessarily remember. Grandpa doesn't necessarily remember that he had eczema when he was 3 years old. But now family history is much more accessible. But the vast majority of people actually do have a family history of what we call allergic diseases. And so things that tend to cluster together based on some of the differences in immune function that are related to these conditions. And so the big ones are eczema, asthma, environmental allergies like hay fever, those sorts of things. And then there are an array of more rare allergic type diseases that can affect like the GI tract and other things that can also cluster as well. That family history is really important because it does tell us that this root cause, the driving forces in terms of the skin itself and what causes eczema, is not something that you could readily change just by changing your diet, for example.
That's really helpful. So as a family doctor, I get to care for families. And it's so interesting because I get to ask the parents and the grandparents sometimes, like, what was the history? What was it like when you were caring for a baby's mom in a way? And they get to share that. So it's really helpful to know the link between genetics and eczema. Beyond genetics, like who else may be more likely to develop eczema?
Well, it's interesting because people have studied this all over the world. Sometimes I have families will say, well, why did this happen to us? And then I sort of give the explanation, and then they'll say, but why? And they say, someone should be studying this. And I say, oh, it's being studied all around the world. Everything from geographical differences, altitude, water composition, you name it, people are looking at it. And again, it's because these external factors that may sort of impact the skin, but it's clear that there are environmental triggers. And sensitive skin is not a medical term, but it is a way that we describe the vulnerability of people who have skin barrier changes like eczema. And so you want to make sure that you're not using things that have a lot of fragrance, things that have extra excipients. And so excipients are the things that give things a shelf life or make a product stable. So if you are not mixing up whatever you're putting on your skin at your kitchen table, and if it doesn't go moldy in a day or two, there's an excipient or something in it to prevent growth of microbes and to keep the stuff that's inside it stable. All of those different things are extra additions that people can develop allergies to or become sensitive to. Then there are external things like latex, many things, thousands of potential allergens that can irritate the skin. So the best approach for someone who has a skin barrier defect, or as people like to describe, sensitive skin, is to keep things as clean as possible. And that's pretty straightforward to do. That's going to be cleansers and moisturizers and products that don't have any color to them, so tend to be clear or white or cream colored, that have no fragrance to them. And it doesn't necessarily have to be dermatologist recommended. That label doesn't really mean anything. It's really about being savvy, reading labels, and making sure that you're not using things that potentially could irritate. So for example, bath bombs, cute, colorful,
favorite
smelly.
in our house. Yeah.
Yeah, everybody loves bath bombs, including my house. But the problem is they're like all the wrong things to be putting on skin that's sensitive. But it's not all or nothing. We can't be super militant and just walk around in, white bags with sterile white creams. But it's one of those things that if your child is having a bad flare or is, being itchy, well, then that's probably not the day for a bath bomb. And you right. really keep those for like a really rare treat. But it's those environmental factors, thinking about those things and how that can play in the role in the skin, in addition to those genetic factors. That's the hope, right? That's why you can manage eczema so well, because there's all these mitigating things that you can do. Picking fabrics that are not irritating, like wool is probably not the best choice for someone who has eczema. So 100% cotton clothing. Humidifier in the home, keeping water, hydration in the air. That's really important, particularly for newcomers who come to Canada.
Yeah.
New immigrants who may have come from a place where it's much more humid, they will then get here and their children start to exhibit symptoms. And it's really important that we proactively talk about that a humidifier in the home can be really helpful too. Mm-hmm. So you can see there's lots of things. Parents will say, there's nothing we can do. There's so many things we can do, even though that this is genetic.
Now, I love that. I love that, just kind of breaking it down and making it very, kind of simplifying things. And we have some more questions that we want to get into in a bit, just about things that can be done and things to avoid. One thing I think that, we all see this, I think, in various different diseases in our practices, is how diseases can present differently across different populations. But in skin conditions in particular, are there differences in how eczema presents across different skin tones?
Yeah, so that's a big favorite topic of mine in particular. So there's a few different things. So I will start by saying something that's fairly controversial. And that is,
we love controversy.
I love it.
We love controversy.
And that is, as a very proud dermatologist, for many, many years, we taught how rashes and skin conditions look mainly in white skin. And so what that has led to is a significant disparity and delay in appreciating skin disease, like the same diseases, but like in two different skin types. And it's not just about dermatologists. It's about primary care.
Yeah,
It's about
100%.
emergency room physicians. It's about surgeons. It's about everybody. And so we've sort of had to claw our way back. And part of that is understanding what are those differences. So there's a few right off the top. The first is eczema is an inflammatory condition. So when you have inflammation in white skin, it's usually red or pink and looks inflamed. And so even in patients with slightly pigmented to darkly pigmented skin, you will see that often that bright red or pink isn't there. It might be gray, might be brown, might be ashen, might even be pigmented. And so people will then get labeled that this is like after the rash, it's post-inflammatory. But then if you just ask, how itchy are you? 10 out of 10, they'll tell you it's still very active. But you can see active conditions get treated, or at least patients are given instructions to treat, whereas they're often told when it's brown, when it looks gone away, stop, right? And so that's a big thing I see in my practice. The second is the distribution. So dermatologists were very much on pattern recognition. Rashes like to start here and go there, and it fits. And so for many years, we taught that eczema is on the inside of the arms and the backs of the legs.
Yeah, I remember that.
And as a differentiator, for example, from psoriasis, which is on the extensors, like on the backs of the elbows and on the knees. But what's interesting is by being intentional and studying what the differences are in patients, for example, with brown and black skin, it's actually quite common to have it on the extensors, so not in the backs of the knees. And so that leads to diagnostic challenges, right? Because you might see a person, you might assume they have psoriasis if they have black skin, but it's actually eczema. And then the third thing I would say is that there are actually specific or special variants of eczema that really we only see in pigmented skin. So there's one called nummular eczema that often it's coin-shaped eczema, big, thick, circular plaques of eczema. They're thicker, they're tougher to treat. They're often misdiagnosed as ringworm or tinea and treated for weeks and weeks and weeks. Meanwhile, the person's itchy and getting more dyspigmentation. And then the most common presentation of eczema, for example, in black children is something called follicular eczema or papular eczema, where there's like tiny little bumps and it doesn't really look as rashy as the typical eczema. That's not to say that people with pigmented skin can't have the regular eczema too. But what I say regular as in the one we've described in white skin. But recognizing these newer variants is really important. The last controversial thing I'll say, which I actually don't think is too controversial, when you're intentional about looking at who is the most affected or who is the most severely affected by something, you learn these answers. And so there's lots of data to support that Black children and Indigenous children in particular have more severe versions of eczema. They're more likely to have delays in treatment and so on. And so I think that's why that question that you asked, see, I went on a little bit too long about it because I'm so passionate about it, is really key because that's how we name it and then we claw our way back and then we change it so that children of all backgrounds, hopefully will eventually have similar outcomes with respect to their eczema.
Thank you for take all the time that you need on that kind of topic because Shaz and I talk about equity and ensuring that our patients are all treated in a way that is understanding that there are huge gaps in the healthcare system and how we were taught medicine, where we're under-recognizing things and under-treating as a result. And so this is such an important part. I'd say this is one of the most important lessons of today's podcast so far. I know there's going to be others, but for people to recognize that, especially those who are listening, who are medical learners or healthcare providers themselves, to recognize that there are differences in how skin conditions present and how we have to be alerted to that.
And a special thank you to episode sponsor, Aveeno Baby. Aveeno Baby understands that every parent wants the best for their children and is committed to helping every baby feel comfortable in their skin by offering nourishing solutions. It can be challenging to properly care for your baby or toddler who is uncomfortable due to eczema, so following a daily skincare routine of bathing and moisturizing can help keep your baby's skin under control.
The Aveeno Baby Eczema Care line is a hypoallergenic and free of steroids, fragrance, parabens, and phthalates. The Eczema Care range is clinically shown to help temporarily relieve the symptoms of eczema like itch, dryness, redness, and irritation. You can find Aveeno Baby at your local drugstore. I want to build upon a little bit of controversy here myself, because this is one that comes into my office often, where people will say, Dr. Sheila, can you please send us for allergy testing? We have done a dairy elimination diet for our kids because they have eczema, and they've eliminated all these different things from their diet because they really think that this is associated to the eczema and the severity of their flares. Can you tell us, do food allergies or sensitivities cause or worsen eczema?
Oh, you went straight for
Yeah.
it. And I love it. Another conversation that I probably have on repeat multiple times per day. I get why people ask it. It goes back to, when we started, people are searching for that reason. And they're getting all that feedback. Basically, they're internalizing it. Like, what is it that I'm doing? So I often, this is my response to parents, and it often blows their minds. So I say, no, food allergies do not cause eczema. And in fact, eczema causes food allergies. And they stare at me. And then I say, so this is why we really need to focus on treating the eczema. So why is it? And then I quickly tell them, and the allergists and the dermatologists agree on this. And it's actually quite simple. If you go back to that skin barrier discussion, when the children are doing that adorable baby-led weaning, where they're all the things, all the food is everywhere, on the wall, on the floor, it's also on their face, on their skin. They're usually naked in their high chair. The point of when you first get introduced to food is it is supposed to go in your mouth, into your stomach, and into your body. But when you have a skin barrier issue, it's being exposed through your skin as well. And that is leading to an abnormal immune response. So in the first year of life, if you have poorly controlled eczema, that increases your risk of developing food allergies later. So if you can control the skin, then you can reduce the food allergies. So it's actually the other way around.
Wow.
This is
that
like,
one's,
that's
one's
another,
mind-blowing for me. Wow.
because it tells us how important it is to treat under the age of 1, especially because now we're saying, peanut allergies are going up. All these different allergies are going up. We're trying to introduce things earlier at 4 to 6 months of age with the high, the high allergenic foods but then it is everywhere. So do you suggest that kids then have like a barrier cream on when they're being introduced to foods, so like Vaseline or something?
Okay.
Absolutely. And so that's our proactive sort of discussion. Not everything is always about a prescription. It's about that barrier protection. This is why in this particular skin condition, what you put on your skin is just as important as the prescription and the frequency with which you do it. Just the same as with a diaper rash, you need barrier cream all the time. It's a similar situation with eczema. So we've got the food situation, then we have the drool. It's a perfect storm of irritant contact dermatitis from the drool, from relatively immature skin, because we're looking at young toddlers and infants, so their skin is not fully mature, regardless of their genetic background in terms of immune function and barrier function. And then on top of it, you've got all of these acidic foods, et cetera, on top of it. So it's like a perfect storm of everything. So if you can protect the skin, that can really allow a minimization of that irritation that's then compounded on other conditions like eczema.
So to summarize that, eczema is not caused by food allergies, but untreated eczema can contribute to food allergies.
Absolutely.
That's, I mean, that is, yeah, that's like, I wonder if we can get CME for this, Sheila. Can we just from like
I
this
feel like we
podcast
should.
recording?
I'm already
But you know
like,
what? The best part of that conversation, other than it being true, is that parents, I think, accept that. I think the other piece I've learned in practice over time, and it's a challenge. It's a challenge because we all have long wait lists. There's relatively few pediatric dermatologists, and people want to see a pediatric dermatologist. But what people are looking for is time. They're looking for time and explanation. And sometimes that's challenging to give. But I would say the majority of time when I have that conversation, parents are like, oh, okay, I don't need food allergy testing. Like there's still some who may,
yes,
who
there
may
are.
push, and
Yes.
that's fine. But I think it's really people are just looking for that information.
Yeah.
So before we kind of get into treatment and prevention, which we've touched on a little bit already, I kind of like a two-part question for you. So one,
Sure.
can people grow out of eczema? And then the corollary to that is, can eczema be developed later in life, even if an adult did not have eczema as a child?
So the first one's easy. Yes, people can outgrow eczema because your skin can mature. It can compensate by making extra proteins to help with that barrier. And you may just have mild disease that, just gets better over time with that maturity. In fact, probably the majority of the kids with fairly mild eczema will outgrow it. The second question, adults absolutely can develop eczema without having not had it previously in life. As I said, probably about 70% of people develop it in childhood, which means like a small percentage or a subset develop it later. And then another big group are the elderly. So senescence of the skin. So we talked about the skin being relatively immature when you're born and gaining that function. Over time, you also lose that barrier function and you get immunosenescence or a loss of optimal immune system function in the skin as you get older. And so that we see a lot of itchy older people with dry skin as well too.
Okay. And then and so like the elderly part makes sense, but like in adults, what is it about their, like, because obviously the skin barrier is changing then, right? If they're developing, or is it that it's becoming compromised in some way, or do we know how it develops later in life?
It's actually not well understood. Some people, there's fancy articles where people have put people in 5 different categories and trying to figure out what it is. But I think there are 2 basic things that I think about without knowing the real answer. The first is they could have just had fairly mild eczema when they were young and, wasn't anything to write home about. So that was already built into their DNA, i.e. they sort of had this genetic setup, and then environmental factors over time, all of the things that I said people are studying around the world potentially triggered it. So, or you didn't have it where you lived before and then you moved to a place and then you do have it. And then I think most conditions in the skin are acquired, right? So psoriasis, you can have it. You can be born with psoriasis or it can come in the first few years of life, but that's actually fairly uncommon. You usually develop it as an adult. And so it may just be that these particular adults with eczema, the condition is just a bit different from the regular childhood eczema.
Right.
The factors are different, like other acquired skin conditions of adulthood.
I have to ask this because I focus a lot on my work on perimenopause and menopause. Just really quickly, I know we're talking about kids, but there are, like, everyone comes in with skin changes and irritation. Is that related to the barrier as well and changing in menopause?
Yeah.
Okay.
Yeah. And so the skin barrier is not, or that dysfunction is not exclusive to eczema. And so there are so many factors. The skin is so complex. It's so complex from an immune function point of view, but also structural things. And then what are the hormonal changes as well, right? We know one of the symptoms of thyroid dysfunction is suddenly having very soft skin, right? And so there's many, many things that the skin can reflect in the body. And so perimenopause and menopause is just one of it. I often say I was drawn to dermatology because the skin is such a great storyteller. You know, and there are conditions that are confined only to the skin, but there's many skin conditions. You look at the skin and you go, oh, maybe there's something else going on internally. And then you sort of solve that puzzle. So I think perimenopause and menopause is a great example of how those sorts of changes can impact areas that you wouldn't necessarily expect, and opportunities for understanding, but also proactive discussions.
Yeah.
Like, how does hormone replacement mitigate some of these things?
Right.
These are all really exciting areas in dermatology.
Oh, this is so great. Thank you for that. So we're also going to switch gears a little bit here to treatment and options that we may consider.
Sure.
So what sort of non-medication options help soothe? You mentioned a couple in terms of the barrier creams, but what kind of things can parents look to use to soothe and prevent these kinds of flare-ups when they happen?
Yeah, I think whether you have mild eczema or what we call moderate to severe eczema and require some prescription in the background, everybody gets the same foundational treatment, which is optimizing the skin barrier. It can start with even just a discussion about baths, which is also quite controversial. Some people say bath once a week. Some people say bath 3 times a day. I think it's how you define bathing. So for us, when we're talking about a therapeutic intervention for eczema, it's putting water back on the skin. It's not using cleansers necessarily every day, certainly not using harsh cleansers. You know, there are cleansers that are formulated that are safe to use every day if people want to do that. But the idea is really putting the water back on the skin and sealing it in with an appropriate moisturizer. That's a common misconception. So people sometimes think I'm putting the moisturizer so that it'll get absorbed into the skin. That's why with thick ointments like petrolatum, people say, oh, but it's too sticky and it's not getting absorbed. It's not supposed to. The idea with these moisturizers is you're supposed to trap the moisture on the skin and then help to support the skin in different ways, pH, etc., to optimize its function. So the foundation is putting water back on the skin, and ideally we think that should happen once a day. I tell new parents, you know, even with a diaper change, take a 100% cotton washcloth, squeeze some water on baby's skin, turn it into a massage. But that should really happen at least once a day, to put that water back and seal it in with a moisturizer. I've alluded to this earlier. Everything that's put on the skin should be mild, not fragranced, formulated in that way, not to irritate the skin. And a big piece of that as well is parents, especially parents of very young children, need to remember that what they put on their skin is the same as what they put on their baby's skin. Because every parent's the same. In fact, mine are older and I still get a arm around my neck hugging me. And, you know, so it's that constant contact. So you can't be using, I don't know, I don't want to get in trouble for a brand, but like Old Spice, and then sort of holding your
like
baby.
Something super fragrant and stimulating.
Super fragrant and stimulating. You have to, that consort, so knowing that you're going to be in close proximity with your baby is an important feature. So I think, to summarize, it really is that skincare piece, putting water back every day, and moisturizing. I already mentioned clothing. So children in general, these young children need to be in 100% cotton clothing. So textiles, fabrics that are irritating is a problem. Humidifier, I mentioned as well too, making sure that we're putting that moisture back. So you can see it's all about optimizing that barrier function.
And, you know, like you mentioned ointments as well. So like you want something that's more of like an emollient that is going to act as a barrier. Is that correct?
Yeah, emollients, thick creams, you know, especially for the younger kids. Like you don't necessarily need a greasy ointment. You can have a very thick moisturizing cream or balm that can be just as effective.
Okay.
And some parents look for additional ingredients in the to help soothe the skin. So one of the things that we recommend is you don't put food-based things on the skin. So I have a lot of families or grandmas and grandpas, usually grandmas, putting in oats, like boiling oats on the stove, putting different food-based products. But again, for the reasons I said earlier, you're sensitizing the skin and potentially increasing the risk of developing an allergy to those things. So if you want to look for some of those ingredients, you can look for colloidal and in different skin products as well too. So it's best if you are looking for some of those additives that may be anti-inflammatory to actually choose a commercially available product that has it, as opposed to putting the food itself directly on your skin.
And so, I mean, so for us, Sheila and I mean, and as physicians as well, like we really like to focus on the prevention piece, the non-medication piece. At what point though, like if, you know, the non-medication options that you just outlined very well for us are not working, what is the threshold where prescription medications like either topical steroids or steroid creams or oral steroids, like taking steroids by mouth into the body, when do those become necessary?
That's a really, really good question. And one controversial statement I'll make
is that this podcast is the most controversial podcast that we've ever had.
I'm so sorry.
I love it.
Never be invited again.
It's so good.
So I'm going to put on my pediatrician hat, and I'm going to say that kids are undertreated. They're therapeutic orphans. We're so worried about risk, and I get it, that they're undertreated. And so one of the things that I like to highlight for other physicians and for families is when they're making treatment decisions, particularly for very, very young children, but for everyone, but for very young children, you have to look at the risk-benefit analysis. What is the risk of the intervention versus the risk of the condition that you're actually treating? And in the case of eczema, when the kids are really young, the risk is really high. And so some of the things that you look for when you're going to institute a prescription is itch. Now, eczema is universally itchy, but these babies, sometimes they do this dance, all they do is wriggle, and you know they're suffering because you need restorative sleep to have proper brain development. And these kids are not sleeping well. You know they're not sleeping well because the parents aren't sleeping well. So if the kid's not sleeping well or the parent's not sleeping well, they need a prescription because it's just downhill from there. The second is the extent of the eczema. Sometimes people are sort of like, well, it's not that bad. It's in one little place. Okay, you can try it. But the more extensive it becomes, it's not going to go away just with moisturizer. You should start a prescription because it becomes harder and harder with a larger body surface area involved for parents to comfortably use prescriptions. I would argue it's probably better to start when it's fairly localized to mitigate a child having to use it in such an extensive area. The third is if a child, and I see this commonly where a child will come in and they're on their 4th course of antibiotics for a skin infection, but they've never actually had their underlying eczema treated. It's unusual, but eczema is a skin barrier issue. So one of the big complications, particularly when you're younger, is having a bacterial, viral. So we also see viral infections like hand, foot, and mouth. When the kids have eczema, it turns into eczema coxsackium, and it's just this horrible eruption all over. And they can even get fungal infections. So I think those are 3 key things where clinicians or healthcare providers can say, okay, you know what? Moisturizer isn't enough. And then my last plug is for patients with pigmented skin or skin of color, because you don't need a lot of active eczema to significantly discolor the skin. And so I would argue that treating earlier is better because the longer the inflammation grumbles in the skin, the more dyspigmentation then results.
I appreciate this so much because a lot of when I try to give a prescription, they've met that sort of those 3 points or the 4 points that you just made, Dr. Joseph. A lot of parents will say, well, it's steroid. And I worry about steroid use. I'm worried about their growth. I'm worried about hypopigmentation, so loss of the skin. Like they're worried about all of these different things that they've read online or otherwise. And I try to sort of say, well, listen, there's a reason, there's a balance of like figuring out the risks versus benefits. Can you just give us your one line? Because I know you have these wonderful lines around like, I'm going to be the patient. Steroids, I worry about steroids. I think it's going to make them not grow as much. I worry about their skin color changing with the steroid use. Can you reassure me?
Yeah, absolutely. So I usually say, we have the same goal. We're going to minimize your child's exposure to steroids, which means that we're only going to use steroids where we really have to put a big fire out. And I'm going to give you a different prescription that doesn't have a steroid that you're going to use most of the time to treat the eczema. That alone usually dispels them using it because we're on the same page. I think their perception is because I'm just going to have to use this all the time. And so I phrase the steroid as the rescue medication.
Right.
And when they sort of see that and they're armed with how to use it, I also then say, oral steroids have a long list of side effects when you take them internally. I also tell them, I've almost never write a prescription for oral steroids for eczema. But when you put steroids on your skin, they are not, and the way we're going to prescribe them, they are not absorbed to a significant way. The way it would be is if you were taking it orally. So that long, scary list of side effects is not relevant.
Okay.
And the thinning of the skin that everybody talks about it, I've never seen it in a child. That usually stops it right off the bat. Now, I can say that very easily, but the truth is thinning of the skin is a cosmetic side effect, nevertheless. So again, risk versus benefit. But when you use topical steroids the way they're intended, that shouldn't happen. There are other side effects that are much more common, like acne, like a little bit of extra hair. I don't use steroids in armpits or growth areas because stretch marks can occur. And so, but those again are super, super uncommon. With the breadth of non-steroidal prescription creams we have now, I think it's much easier to create an action plan aligned with the parents' values, which lets us still incorporate steroids that are highly effective to put out big flares, and then have for smaller flares and more maintenance, the non-steroidals. And people are usually quite accepting of that.
Thank you.
You know, I'm going to put my emerge hat on here because this is often what I do with like when I am discharging people home. When should people worry about eczema and be seen?
I think the impact of eczema long-term is huge on self-esteem, on learning, on self-regulation, on many, many things. So I think even though those are chronic issues, acutely, if the rash or the eruption or the flare of eczema is not better by 4 weeks, they need to be seen. It should be possible to clear a flare of eczema within 4 weeks, no matter what you use. Because sometimes we see people, they're using the same cream, betamethasone valerate, for 6 months, and they're still sort of working on the same flare. And so I arm them with that information. 4 weeks, your kids should be better. If they're not, we need to reevaluate. The second is if they're having pain in their skin. Pain can go with eczema, and that can signify other things like infection. And then, of course, signs of infection, oozing, crusting, those sorts of things is important. But I actually think that piece about not getting better, like clearing an episode and then waiting for the next episode, is really important. So there isn't treatment inertia. Going back to my comment about often these kids are really undertreated and their therapies aren't varied or escalated in a way that maybe they need to be.
Okay, I love it. This has been such a rich discussion. I think a valuable episode for our listeners, just with how common eczema is. We do
for
have
us. I'm like,
and
writing
for us,
in my
I know,
head,
like I'm like taking all these notes too. I love it. We do actually have quite a few healthcare workers who listen to our show, and we love leaving
Sure.
them with kind of pearls, like clinical pearls or take-home points. So what are the top 3 things you want every healthcare provider to know about eczema?
Oh, number 1, it's not just a skin disease. So please treat it. Far-reaching effects outside of the skin. 2, it presents in different ways across people's different backgrounds. So be aware of that because often we don't treat rashes when we're not sure what they are and we wait. I've already explained why certain populations are more vulnerable to more severe disease and delays. So just thinking about those differences and keeping up with that as it relates to eczema. And 3, meet people where they are. There's so much information in social media and so much fear, and parents really want to treat their kids, but they're scared. And so if a parent is worried about using steroids, that's okay. You can counsel them, but make sure that there's something a part of their treatment plan that doesn't have a steroid in it. Really, that communication piece and meeting people where they are, I think it's important.
I love that.
We love you, Dr. Joseph. This is one thing
And
that we,
so fun.
it's so fun. One of the things that we also end on is, you really focused on and helped us understand. I've seen it in my own practice when parents are sleepless, they're worried, they're tearful in the office because they're just at their end of trying to figure out how to manage their kids' skin conditions. And we always like to end with a prescription for our listeners. So can you give us a prescription? What would you share with parents who are managing eczema at home?
You're in the trenches. I've been there. And I guess my prescription is to really be kind to yourself. This isn't anything you did. And to say that there's so much hope because eczema can be well managed. We understand this condition very well. And although we have to tell the truth that we don't have a cure, we certainly have many, many things to make your child's life better and your life better. And so there is absolutely no reason in 2025 that your child has to suffer with eczema. So you are your child's best advocate. We all want to help. And so that's your prescription. Your prescription is to get the help you need and recognize this isn't your fault.
Dr. Joseph, thank you again. Where can our listeners find you online?
Oh, sure. You can find me on Instagram at Derm Dr. Marissa. So DermDrMarissa.
And we'll throw that in the show notes for our listeners as well. Thank you again. A reminder that the Doc Talk is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs. And please be sure to follow us on social media at the Doc Talk Pod and send us any questions you have.